Hello, and welcome to MediSked's presentation, Interoperability 101. A little bit about your presenters. My name is Heather Barr. I'm the Program Manager of Health Informatics here at MediSked. I received my Master's in Health Administration in the early 2000s, right around the time that interoperability was becoming a healthcare industry term. In the years since, I've worked with nurse case managers, care coordinators, wellness coaches, social workers, emergency room physicians, primary care physicians, pharmacists, and radiologists, just to name a few, to get the right information about the right person to them at the right time, despite technology barriers. Now I'd like to introduce my co-presenter, Shayne Champion.
Good afternoon. My name is Shayne Champion. I'm the Chief Information Security Officer at MediSked. I have a long history in both healthcare and information security, including working for Blue Cross Blue Shield of Tennessee, as well as being the Director of Information Security for the nation's 6th largest public healthcare system. We're both very excited to share our experiences with you today, and having experienced directly the benefits of having interoperability work within a medical community, we're very excited to share that knowledge with you. And with that, I'll give it back to Heather.
All right, in today's agenda, we will define what interoperability means, answer your question, what interoperability means for me, talk about how interoperability is relevant for home and community-based services and long-term services and supports. We'll review federal policies and security considerations. And finally, we'll answer another one of your questions: what should I be doing about interoperability? So first, let's get started with a definition. So this definition comes from HIMSS, the Healthcare Information and Management Systems Society. Interoperability is the ability of different information systems, devices, and applications to access, exchange, integrate, and cooperatively use data in a coordinated manner within and across organizational, regional, and national boundaries to provide timely and seamless portability of information and optimize the health of individuals and populations globally. Interoperability is not simply the exchange of data. It only becomes interoperability when the systems are actually able to use the data that's exchanged. So let's use Eliza as an example. Eliza has several healthcare providers at her local hospital, some of whom give her medications. She also has an additional specialist office where she gets other meds, but they are not connected on any medical record system. Well, now Eliza is meeting with yet another specialist, but this provider does not have enough information to make a clear decision on whether the new medications are safe, given the other things she may be taking. Well, some medications may interact with each other in a harmful way. Others can just make certain medications less effective, but neither of these are desirable outcomes. However, if Eliza's information followed her throughout her care, including the new specialist, and all of her medication or information was shared between her providers in a standardized way, this is an entirely different scenario. Now Eliza's new provider can make an informed decision that these new medications are in fact safe for Eliza to take. Our example here with Eliza has to do with her medications, but this could apply to any facet of care. I'd like to think diagnostics like radiology, for example, is a great way to think about this and visualize it. So let's say you're a cancer patient and you get a CT scan every 6 months to track the progression of your condition. CTs deliver a hefty dose of radiation. So at 2 scans a year, that's already starting to feel like a lot balanced against the rest of whatever your care plan may be. So if you go to a new oncologist and instead of your most recent CT, they'd prefer to get an extra one on their machine that'd be easier for them to read, yikes. This is where you start thinking, all right, there has to be a better way for my new oncologist to just read my recent films. Well, those are the key words we're talking about. There's got to be a way. Well, in fact, there is, and that is interoperability. So, okay, interoperability seems great, but what is it really? Interoperability is the way products and systems communicate data where interfaces of those solutions are universally understood. What do we mean by universally understood? We mean that the programming language that the computer systems use to talk to each other is a language they both speak. If one asks for a blood pressure reading, it gets a blood pressure reading back, as opposed to a weight or a blood sugar. That would be really confusing. So they have to speak the same language. This will allow multiple systems to work with each other without any restrictions and with proper permissions. So I want to hit on a couple of these terms. Permissions. This means that users have the proper authority to access and exchange this information. We mean the patient, we mean the provider and the provider's electronic medical record, we being the lab that's processing an order. But regardless, we mean that consent exists. The other term here is restrictions. When we want to avoid restrictions, we want to avoid any necessary fees, unnecessary delays, or any policies like we only share with in-network providers or we only share with certain software applications. All right, so before we go too much further, I need to give you some definitions. First on the list is Health Information Exchange, or HIE. This is the movement of health information among organizations in a confidential, electronic, and standardized way. It also is a term that is used to identify an organization that handles that data exchange. Most states, patients have the option to opt in to share their data, but there are a few states where everyone in the state is opted in unless you opt out. Another key point about HIEs is that this term is often used interchangeably with the next term, RIO, Regional Health Information Organization. But RIO specifically refers to the governing body in a region that coordinates data sharing agreements among providers. Next on this list is CDA, Clinical Document Architecture, which typically refers to an electronic continuity of care document, but it can also mean other things like progress note or discharge summary. There's an additional term, Consolidated Clinical Document Architecture. Now this, c-cda, is a set of rules that make CDAs easier to exchange. Last here is FHIR, Fast Healthcare Interoperability Resources. This is created by HL7, a healthcare standards organization, as a specific way to handle data formats for exchanging electronic health information, and FHIR is intended to replace CDA. There's more. Third-party applications. These are software applications that are made by a company other than the electronic medical record in question or the device manufacturer. Third-party apps are what you think of that are beginning to appear in the market for a patient to view their health record like on their smartphone, on their tablet, with the intent of being able to connect to many sources: the insurance company, the primary care provider, specialist, day hub provider, etc. Electronic health information, EHI, is patient data stored in an electronic form that is both captured as a result of healthcare delivery, as well as used and shared for healthcare delivery and public health reporting. This is very similar to PHI, or protected health information. The difference is that protected health information only applies to information created by a HIPAA-covered entity. EHI is much broader and includes information provided by the individual. Application Programming Interface, or API. This is the software intermediary that allows for separate applications to interact and share information. So we talked about FHIR a moment ago in the previous slide. FHIR is more or less a language that software can speak, while an API is a common mechanism that software can use to share information. And lastly here, information blocking. A practice that restricts authorized use or exchange of EHI unnecessarily. We're not going to go into too much detail here, although Shayne will be touching on it later. We could honestly have a whole other webinar just on this topic alone. I think it's important, though, for you to be aware of this term because the information blocking rule just went into effect in April, so there's quite a buzz about it in the industry right now. For a very brief history, this is just a high-level overview. If you are interested in details, please feel free to reach out to me by email. My contact information will be at the end of this slide deck. Allow me a few graphics here to illustrate what I'm going to call the evolution of interoperability, using the acronyms you just saw on the previous two slides. So starting in the early 2000s, the healthcare industry kind of realized that these neat electronic medical records that we were creating weren't talking to each other. So this led to solutions like HIEs and an electronic version of that continuity of care document, which is broadly in place today, although adoption levels are variable. However, neither of these solutions is a common technical language that everyone has adopted so that software can speak well. So fast forward a few years, this is where FHIR comes in, along with APIs and third-party apps, in the hopes that these technologies will move us to a true interoperable state. Well, why do we need it? What's the big deal? Well, honestly, it's really a good idea. It puts individuals first, giving them access to their health information when they need it most, and in a way they can best use it. Interoperability allows us to respect the most important person in relationship to a patient's data, the patient themselves. Each of us is the most important person in relationship to our data because it's about us. It wouldn't exist without us, and with it, our providers can take care of us. Interoperability is simply a framework that allows us to share our information with all our providers. It promotes transparency through technology, providing opportunities for providers to gain visibility into the range of care and services an individual is receiving. And it fosters innovation in health and human services to deliver better information more conveniently to both patients and their providers. Both health and human services are pretty late to the game in terms of technology. You can use an app to buy stocks. You can ride in a self-driving car, but we still use paper. We still use binders, and we still use fax machines. So we need interoperability as an impetus to innovate and bring us into this century. The benefits of interoperability are numerous. It improves quality, outcomes, and performance, improves coordination of care, promotes person-centeredness, engages the individual and their circle of supports in the health information process. It improves safety by reducing errors. Talking about quality and outcomes, this is a great outcome. It streamlines procedures by eliminating superfluous paperwork. Again, better performance, better coordination of care. Streamlining procedures would certainly impact both of those. Reduced overall medical costs. This is obviously a quality outcome we want as well. Shares information across healthcare and social services. Allows for more robust data across populations. And the last one here that doesn't maybe feel like it fits is protects intellectual property for health IT developers. We really want this because protecting intellectual property will spur smaller developers to create those third-party apps, as opposed to only the software giants. More competition to make great products. Now let's answer a big question you may have. What does interoperability mean for me? So from an individual perspective, it allows me to be the center of my own experience of care. I select the additional providers who can see my information. It's not a one-time decision. I can always change what I would like to share going forward. But this is really about those permissions. As an individual, I decide. But there's also a customer aspect we should not overlook. I don't have to tell my story maybe from the beginning every time. I don't have to relive my previous experiences maybe unless it's truly necessary. Let's be honest, this is sensitive and sometimes traumatic stuff. It can be exhausting to tell my story over and over again to different providers. So if my provider were able to look over my records ahead of time and ask me for more detail only when needed, wow, that sounds like a way better experience of care. So we have an image here on this slide of Eliza kind of surrounded by her data. She's at the center, and whether her data is from a public health registry, her health plan, her pharmacy, her doctor, her day services provider, all of this information should come together to tell a cohesive story about Eliza. Okay, so what does interoperability mean for me if I'm a provider? As a service provider, I can see where my individual received healthcare, what was ordered, who ordered it, and any related results with no special effort. This is, of course, assuming consents are in place. And as a healthcare provider, I can see where my patient received services, what types of services, charts, progress toward goals, again, with no special effort. I know I'm really hitting this home. So additionally, though, as a healthcare provider, it allows me to be a little more informed before I walk into a room to make that first contact. I spoke before about trauma. If I know ahead of time, I can employ some soft skills to be sensitive to what an individual or patient has experienced. As a care manager, I don't have to wonder if an individual got a service. I can see it. I can also be alerted to new information, like a hospitalization, and I can see the discharge instructions, yet again, with no special effort. Checking to see if something was completed could mean the click of a button as opposed to 3 phone calls. It's possible that many of you as providers have access to this information now, but the key is, how hard is it to find? How far do you have to dig? So I want to tell you a short story about Christine. She's a care manager I worked with at a large healthcare organization. Christine says to me one day, she says, Heather, I need to get the discharge instructions for my patient. She went to the hospital across the street instead of to our hospital. I need to arrange services for her, and she's already been home a day. The clock is ticking. I say, okay, but unfortunately, we don't have an integration built to that hospital. You should be able to log in to the exchange and get that information. So she looks at me and she says, well, which login is that? And I'm saying, and I look at her and I'm like, no idea. Like, I would know her login. I don't know her login. So she says to me back, she says, did you know I have 27 different logins? I counted one day, 27. That's how many systems I have to log into to get information that I need to take care of my patients. That's a lot, right? That's a ton. So this is what true interoperability is trying to get to, an end to that madness, to allow you as a provider to see everything you are authorized to see and to provide care in a holistic way. So now I'm going to use what MediSked offers as a great example of how interoperability can impact home and community-based services and long-term services and supports. Christine, my care manager with all the logins, let's say she's a MediSked user now, and she's much happier because care managers get real-time notifications for hospital admissions right within the platform. Christine is notified that Eliza is in the hospital right on the main screen. She sees that Eliza has broken her leg. Well, she knows that Eliza is working on preparing meals for herself. It's right in her plan, and she gets support with these 3 days a week. Christine is worried about this. She's concerned that learning to prepare meals and handle crutches in the kitchen is going to be difficult to do. So Christine arranges a meal service for a couple weeks, and then Christine uses the MediSked portal to message the entire team including Eliza and her natural supports about the updated plan. MediSked supports interoperable solutions for today through integration with HIEs, and we have an amazing team of engineers who are getting us ready to support FHIR and exchange data via APIs. So the value of data sharing can't really be overstated. I list a few additional use cases here, but there are many more. Natural disasters. Thinking about the wildfires in California, Hurricanes Katrina and Harvey, many folks were unfortunately completely displaced. With a more uniform system and process of data sharing, they wouldn't have to start from scratch. Public health crises, like the one hopefully winding down right now, interoperability would have made COVID tracking and reporting a lot easier. Care transitions. From acute hospital to nursing care facility or long-term hospital, from long-term care to residential services, one state to another state, all of these could be easier with interoperability. And finally, value-based care. If you, as a provider, are involved in a quality program where you have dollars tied to achieving certain outcomes, it's way easier if you can track those outcomes. See, everyone I care for needs to see their primary care physician once a year. If I can track those outcomes, no matter which EMR the doctor is using or which insurer pays for the care, that would be great. So you can see how the benefits of interoperability are certainly real. This is definitely a place we'd all like to be. So at this point in the presentation, I'm going to turn it over to Shayne to talk about relevant federal policies and security considerations for us to think about on this journey.
Thank you, Heather. So when we talk about federal policies and security considerations, obviously there are a number of policies out there. So let's take a look at this from a historical perspective, looking at it from a timeline. So the HIPAA was passed in 1996, the Health Insurance Portability and Accountability Act, and it has a number of privacy and security rules, two main sections that involve today's discussion around interoperability, and a little less than 150 guidelines. But to really put this in perspective, taking a look at this image that we have here of a cell phone, this was a state-of-the-art cell phone during 1996. Also during 1996, you had America Online and Hotmail were by far the two leading email service providers. We're talking about 8 years before Gmail would even come to being. But the internet was very much in the infantile stages of its development. In 1996, you only had about 10 million users worldwide of email, which is about 0.25% of today's approximately 4 billion users. And when we look at that on a chart, we can see how much the internet has grown. And how this applies to HIPAA is when they developed the HIPAA standards, they didn't realize that one day you would have over 96% of US users all involved in one contiguous online network. So the HIPAA standards were developed in order to protect the privacy of information that was being shared, but they couldn't really think about things in terms of the extensibility and the amount of cooperation and data sharing we could have available to every single household in the United States through the internet. And because of that, you continue to see the development of additional standards over time to help support that. One of these in 2006, the National Institute of Standards and Technology, which is a subset of the U.S. Department of Commerce, published the NIST Special Publications, or SPs, and the primary one that drives around security is NIST 800-53, Security and Privacy Controls for Information Systems and Organizations. Now, if you've never had the benefit of working within the NIST regulations, there are about 18 families of controls, which end up being just under 1,000 total controls. And the number that apply to you are based on the categorization of risk of your data, whether that's high, medium, or low. Now, if you're not familiar with NIST, there are a few kind of keystone documents that's probably important for you to be aware of. NIST 800-27 is their security engineering guidelines. One very important one that we'll talk more about in a minute in terms of interoperability is 800-30, which involves how to do risk assessments. 834 shows us how to do contingency planning, very important in the COVID age. 800-37 is a risk management framework. And then 800-39 is information security specific risk management. 800-40 is about patch management. 853 is the security controls that we just talked about. And then 800-55 are performance metrics for information security. All of these, as you'll find out in the NIST environment, it's really a maze of cross-references. But these are, if you only know a few documents, these are the key ones to know when you're working in the NIST environment. But this started giving more specific guidance to how we do information security, particularly as it involves things like working with CMS. For example, the CMS minimum security standards, the CMSRs or requirements, those are all based on NIST 800-53. They're just a little bit more specific and a little bit more difficult to implement. But many of the things, the common information security concepts that we're familiar today on an industry basis actually come originally from NIST. For example, most of us are familiar with the concept of a minimum password of 8 characters, at least 1 uppercase, 1 lowercase character, 1 number, and 1 special character. That was all driven by NIST requirements back in 2006. Then the federal government realized, hey, we're not really doing enough. And so they added the HITECH, or Health Information Technology for Economic and Clinical Health Act in 2009. And the HITECH did a couple of things that were really important. First of all, the meaningful use program. How are we using the data and making sure that's happening in a purposeful way? But they also realized now that the internet had become such a big deal, because we're talking 13 years after the original implementation of HIPAA, they saw a future for moving everything to electronic medical records, or EMR. As was discussed earlier, we know that most hospitals, even today, a lot of hospitals still do everything, or care providers, with pen and paper records. And obviously that doesn't scale very well in a very connected world. So they had requirements around that. They also realized that HIPAA wasn't being enforced appropriately. So there are additional provisions within the HITECH to enforce the privacy and security rules within the HIPAA standard. Realizing that HIPAA was in fact flawed, they passed additional changes to HIPAA in 2009, adding rules for covered entity privacy breaches. So from a HIPAA perspective, they're only really concerned about protected health information, PHI, and the scale of controls you need to put in place are based on your role in the healthcare providing chain and the number of records. So if you have a breach of more than 500 records, they added requirements that you had to send a notice to all impacted parties and to the media to notify the public. And then again, in 2013, they added the omnibus rule, which had additional regulations around electronic record requests and limitations on how that information, that PHI, could be disclosed so that it wasn't being exploited for marketing and fundraising purposes. Then in 2016, we had the 21st Century Cures Act. This is where things really started changing, because this is where the federal government understood that the exchange on a secure basis of all of that EHI, electronic health information, was really important. And they wanted to do this to where it didn't cause additional burden on the part of the user, whether that's the patient or the user from a clinical perspective or from a billing perspective. So this allows complete access, exchange, and use of all electronically accessible health information as permitted under state and federal law. And very importantly, as was discussed earlier, also making sure that there's no information blocking in this process. And again, just to refresh you, information blocking is any practice that interferes with, prevents, or materially discourages access, exchange, or use of EHI. So the reason for this was when we think about HIPAA, HIPAA was about sharing the minimum necessary amount of information to make sure that only people who had a justification were able to use that. We're now talking, 2 decades of people being used to the HIPAA regulations and restricting and pulling back access to that data whenever possible. Now they're saying we need to make sure that we're not inadvertently blocking the sharing of information by being too selective about how we implement security. And that's a big part of the information blocking requirements. Then in 2019, the TEF, or Trust Exchange Framework Draft 2, was published. And now the federal government said we need to start standardizing all of the terms, conditions, and principles around how we're going to exchange EHI. And basically to give a common framework for what that data looks like and how we're sharing the information back and forth. And it also scaled it to make sure that EHI was available when and where it was needed in a secure manner. Again, realizing that we can do this securely while still sharing that data. Then just last year, the ONC published its final rule. And in their final rule, it makes sure that the certification program ensures that certified health IT systems can send or receive electronic health information in a structured format. Again, building off some of our previous regulations to make sure that there's a commonality in the way that data is being shared. And then APIs, those application programming interfaces we talked about earlier, now they have to be certified to make sure that they're providing access to all the required data elements. And those are tested and certified to make sure they meet operability requirements for data exchange and availability. So what they're talking about here is they wanted to make sure that these systems communicated in a standard format and that that was tested before these systems are released out for general use. And this is very, very important because now you have a set of guidelines making sure not only, well, this is the way that we're doing it, but now validating that's being done correctly before those systems are available. And then they also, as we talked about earlier, to make sure that the access isn't blocked, that we don't have the information blocking. That as a condition of certification, you cannot restrict communications related to usability or interoperability or security of the information. Then later in that same year, CMS published its final rule. And as part of their final rule, they implemented API standards. And this gets back to FHIR. So now that there are specific standards around how APIs can be implemented. Making sure that payer-to-payer data exchange for anyone involved in that Medicare chain of patient data is provided within those applications. And also to make sure that any of the electronic notifications are sent anytime somebody was admitted to, discharged, or transferred from care. And that way everybody in the chain was aware that additional health information was available. And I can tell you from the public hospital system I worked at, we implemented a very large EMR at a time where, of course, in the healthcare industry, there's a lot of acquisitions, and we have multiple systems working that didn't communicate with each other well. And some of those practices were also using paper records, which really slowed down the exchange of information. Once we put the entire system across several states on one EMR, it was an incredible increase in efficiency, as well as the standard of care we were able to provide for all patients within the system. And it was immediately noticeable. And now interoperability is attempting to do that same thing on a national scale. And the last thing the CMS final rule does is, as I was talking about earlier with FHIR, you now have FHIR as a foundational standard to support secure data exchange via its APIs. So again, it's the standard that tells APIs how they're to operate and communicate. So when we look at this from a trend standpoint instead of a specific individual regulations, number one, we see as time goes along, we keep getting more and more statutory and regulatory guidance. And the reason for that is the government learned that going all the way back to HIPAA, things can constantly be improved as the technology advances, as capabilities advance, and they see what can be done. And ultimately, we're all doing that to make sure that the individual gets better results in their care and that they have access to their information. And also, the whole of these changes improve the specificity of interoperability rules so that it's more clear what interoperability looks like on a national scale so that we don't have individual implementations that don't work very well together. And of course, that would be antithetical to the progress we're attempting to make with interoperability as a practice. So this obviously creates a dichotomy for us. When you have a user and they want to share their information, whether they're going to a hospital or a provider, how do we share, but making sure that that threat actor, that bad guy, can't also have equal access to that technology, right? You've got the whole thing between how do we ensure privacy, how do we make sure we have security while enabling sharing. Well, it turns out information security has a general statute that helps us answer that question. It's what we call the CIA triad. And the CIA has specific meanings. The C is confidentiality. How do we make sure that only the people authorized to see a certain set of information can see that data? Integrity. How do we ensure that that data is not transformed without authorization during that process of sharing, processing, or storing? And then availability, making sure that information is available to all parties. And at the end of the day, this is really a big part of the problem that interoperability is attempting to solve, making sure that that healthcare information is available not just to the user as they need it, not just to that the individual that we're all attempting to serve, but also making sure that all healthcare providers through that chain have access to the data to provide the highest level of healthcare possible. So now when we take a look at some of these standards in relation to each other, the two major ones we have. So you have HIPAA, which is designed to protect shared information, focused specifically on protected health information, the PHI, and the risk is based on primarily the number of records, but it's only, no matter how many records, it's only really concerned with PHI. Versus NIST, which says all information should be protected. It's just that some information is more sensitive than others. Now, there is a classification. Again, I told you there's a cross-reference vortex you can get sucked into as you start getting into that NIST environment. The NIST 800-171, Protecting Controlled Unclassified Information, Non-Federal Systems and Organization, it actually has a classification for data called Controlled Unclassified Information, or CUI. And EHI and PHI would be a subset of CUI. So that's, if you're really looking for a way to specifically give you a little bit more guidance on how to protect that information, 800-171 is a good way to do that. But obviously, this creates a balancing problem for us, right? Because on one hand, you've got HIPAA, which says it's only about PHI and based on the number of records. And this, it says, well, all information should be protected, and it's not based on the amount of information, but rather the classification of information. How do we reconcile these two? Well, there are ways to do this, but this really shows you that ultimately the government, sometimes they do create problems instead of solving them. And as funny as that is, it has an added value of unfortunately being true. And these are the realities that we have to work within our organizations. But there are some security solutions for this. So when we think about it from a confidentiality standpoint for interoperability, first and foremost, identity access management is extremely important. Making sure that we're still using the principle of least privilege so that data sets can only be accessed by the people who have a need to see that in order to provide the care. Also encouraging the use of multi-factor authentication to make sure that we're validating or authenticating the user before we authorize them to see a certain set of data so that we validate that user as who they say they are. Also making sure that we're encrypting all of that data, whether it's in motion or at rest or being processed. Now, the kind of gold standard for how we encrypt data from a NIST perspective is listed in the Federal Information Processing Standards, or FIPS 140-2. You'll constantly see that with a lot of different regulations and sometimes even referred to in HIPAA. But if you want to go to how you really get to encryption, the base document is 140-2. Also making sure that we have transport layer security, or TLS. Currently, version 1.3 is the most current version. I hope none of you are using version 1.1 now. That's been deprecated in most environments and really should be in yours. And everybody should be working towards getting the 1.3 standard in, but making sure you're encrypting those end-to-end communications is really key to that. Also, making sure that we're securing the integrity of all the data that we're sending. Again, going back to encryption, and encryption is more than just TLS. And this link, going back to another NIST site, actually has a kind of an index of all the encryption standards and cryptographic standards that NIST has. So if you get lost or you don't know where else to go, that's another great resource for you. You also have hashing of the data. A hash is a one-way encryption function that you can use. And what it does is it creates a digest of the fixed links that you can verify against the original source. And if the output isn't the same, then you know that information has been changed somewhere along the way. And hashing is a great way to validate the information wasn't changed between the source and the destination. Another thing that's very important is API security, making sure that we're the vendors you're working with are maintaining the security of those API elements they have that's working as an interchange of information. And Heather talked about APIs a bit earlier, but we actually use APIs every day. For example, most of the apps on your phone are really just a collection of APIs. Facebook is a great example of that. And those APIs are making standards for how data is sent from one source to the other. For example, from their servers to your phone or to somebody looking up your profile. But API security has actually become a huge issue within information security. Just a few days ago, that ISAC, which is the information sharing center that the federal government has established to help certain critical sectors throughout the country, released additional information on API security. And we'll be happy to include that on the email that we send to all participants in this webinar today. But it's got some really good guidelines that you should consider when you take a look at either your own APIs that you may be developing internally or the APIs you're using from your vendors. Then we have availability. And remember, that's the problem that interoperability is solving. It's making sure that everybody who needs or should have access to a patient's information, including the individual themselves, have access to that when and where they need it. And that's really, really critical as we look through this entire process. Now, from a brass tacks perspective, let's talk about what your next step should be when you consider interoperability for your environment. So the first thing you need to do is ask yourself some questions. And the first question is, if you're a decision maker or decision influencer organization, how easy is it for your care providers or care managers to get data from other parties? Is it an easy part of their workflow? Are you leveraging the data sharing that your vendors are offering today? If you can't answer those questions easily, then you need to look for a provider that can do that and is looking at those interoperability standards so that that's happening in a unified way that's going to be more future-proof to continue working with systems as your organization grows and develops. You also need to ask, if you're thinking about upgrading a system, does the vendor you're considering have a plan to support FHIR and those APIs, and does the vendor use APIs to exchange records? Those are all very important because that adds, those elements speak to the standards that are being produced as a part of interoperability and are definitely questions that you should be asking. But the obvious problem here is, where do we start? What are all the right answers or the right questions to be asking? How do we really evaluate a system to make sure that that system is providing the applicable APIs that are meeting the standards for FHIR? Well, fortunately, CMS provided a solution for this. In 2018, they started producing a set of documents that pretty much give a checklist, and it's correlated back to HIPAA standards for things you should be checking to make sure that your solution is appropriate interoperability and meets all the requirements. And this all starts back with security risk analysis. Now, if you're not sure how to conduct a security risk analysis, if you remember back to our NIST slide, NIST 800-30 is an entire document about how to conduct a risk analysis. And it's a great place to start if you don't have other policies or procedures in place within your organization to do that effectively. But that's definitely the first step. Do a security risk analysis of the solution you're taking a look at. Another requirement that you have is implementation of audit logs and reports. And what we're talking about from this perspective is really from a security audit and logging perspective. And the primary goal of that is to make sure that we can validate and go back and look historically at who accessed what, and that those records haven't been tampered with and have what we call non-repudiation, or that we can validate that each activity that was conducted within that system ties back directly to one specific user so that we can give accountability for actions performed in the system. And that helps us not just in terms of hacks, but also to make sure that people didn't look at information they shouldn't have had access to. Another really important thing we want to be looking at from an interoperability standpoint is to make sure that the end user devices are encrypted themselves. So it's not just as the information travels, but the device that that lands on should be encrypted as well. And there's some really easy ways to do that. Most people are familiar with BitLocker. There are a lot of other similar solutions, but it's not just a good idea from a compliance standpoint, but if you remember, if you have really great encryption and compliant encryption, usually AES 256 or better on your end user device, if that device gets lost or stolen, then you can benefit from the safe harbor provision, and it reduces your reporting requirements from a HIPAA standpoint. So it's a win both ways to make sure that all those endpoints are encrypted. As we talked about a little bit earlier, access control is extremely important. We'll go a little bit more detail on that in just a second, but making sure that you're authenticating every user before they enter the system and that they can only have access to data that they're authorized to have access to, preferably through the use of role-based access control or RBAC. And again, they have some requirements around that in that guidance document. Another item is making sure you have automatic timeout so that sessions aren't left running past when they need to. Also make sure that if the user walks away from a terminal, that sensitive information isn't displayed for anybody that walks by. So that's very important. Data integrity checks, we've talked about some of those fairly extensively in the previous slide. But again, the checklist has some requirements you should be looking at there. Another big thing is trusted connection. And that's making sure that you have predefined connections between you and another provider that you may be sending data to, primarily through the establishment of a secure tunnel, like an IPS tunnel, and TLS tunnel, to make sure that you already have pre-negotiated secure points between those two, but also making sure the emails that go back and forth are encrypted and running through that tunnel. Data encryption, we talked about in fairly good detail, but this is getting down to a little bit further level. Again, I would refer you back to FIPS 140-2 and the link that we provided in the previous slide. Data hashing, again, hashing is getting a digest value after an encryption algorithm that you can compare against the original to make sure that information was not altered during transmit, and therefore you can trust that. And also from HIPAA standpoint, making sure that you have great disclosure tracking. And that's to make sure that you can give a log, if requested, of who accessed what data and when that data was released, who did it, who it went to, and when that happened. All those are very, very important elements. Now, these are all good general things to take, or specific things to take a look at for interoperability, but what about some general things that we should be doing? Well, number one, remember that interoperability security is an and, not an or. One of the big problems that we have today is that people think, well, I can either be secure or I can share. But it's not an or, it's an and. We can still protect that information while we share, as long as we do the footwork ahead of time. We can still provide confidentiality, integrity, and availability for all that data, because at the end of the day, good sharing in a secure way is what's going to be have a better outcome for the individuals that are involved in the data that's being going into the system. Another big thing, and we're going to hit on this in detail, identity is the perimeter. A lot of people attribute it back to Ronald Reagan, who said, trust but verify. The truth is it's probably a little older than even Ronald Reagan. But the reality is we can't assume that any user on our system should automatically have access to everything. And some of you may or may not be aware, but on May the 12th, President Biden released a new executive order on cybersecurity called the Order on Improving the Nation's Cybersecurity, which you have a link to at the bottom here. And it had a very extensive set of new guidelines that the federal government would be required to comply with specific target dates for when those will be implemented, starting at 30 days and 45 days and 60 days and 90 days and keep going on through the next year, in order to make sure that there's additional security controls implemented for all government systems. And this was done largely in response to the SolarWinds hack, which happened back on December of last year, as well as the very recent Colonial Pipelines hack, which had a tremendous impact on fuel flow and fuel prices throughout the Southeast. But one of the requirements, I believe it's in section 9K of that document, President Biden specifies that all federal systems should go to zero trust networking. Now, if you're not familiar with zero trust networking, it's a concept that's been around since the early 2000s and is continuing to gain some traction. But essentially, what it does is it says that every user who comes in your system needs to be fully authenticated before they come in, preferably two-factor authentication, which is another requirement in the executive order, and that every step, every application, or every piece of data they intend to access, that users reauthorize at every point to make sure that they're only getting what they should have access to. If you're not sure where to start this, Google actually recognized this as a cloud provider themselves. They realized several years ago that it wasn't practical to have that traditional castle model that you see in most corporate networks, where you have kind of a firewall on the outside facing the world and then a wall around the rest of your data. In their cloud environment, that simply didn't work. And so they came up with a concept called BeyondCorp. If you're not familiar with that, we have the link here, cloud.google.com/BeyondCorp. They have a series of, I believe, 6 white papers that talk about their journey to getting to zero trust networking, as well as some of the implementation lessons that they learned and some of the techniques and tools that they used. So if you're not sure where to start, that BeyondCorp is a great place. But here's the reality. The reality is that if you look at historically, because there have been other presidential orders on cybersecurity, it usually takes 18 to 24 months once that executive order goes into effect before that starts percolating back out to entities associated with the federal government. For example, those of us who work with Medicare. So if you're not already doing zero trust-based networking, you should probably get ready, because as a result of President Biden's executive order, that will probably become the requirement for all of us eventually. Because at the end of the day, all cloud-based computing, you know, the old joke goes, it's just somebody else's data center, but it's really true. And interoperability is going to take this to a next level. It's not just what's in the AWS environment. It's the data that comes from hospital A going to provider Y. And so everything is the cloud, because it's just somebody else's data center connected to your network and you're pulling data out of it. And so we're going to have to take a look at that in a very real way. Also, API security, I mentioned this earlier at some detail, but make sure that you're maintaining security over your own APIs, as well as those that you're using from vendors, to make sure that those are being validated, because that's really important. And this is a commonality. It's kind of a weak point within all programmatic systems. And so you need to make sure that you're validating that. And at the end of the day, the last tip here, cybersecurity basics still matter. You need to make sure that you're providing cybersecurity, all of the basic cybersecurity that you're supposed to be doing for the last 20 years. Good password hygiene, making sure they're complex enough and being changed regularly enough, making sure that you're patching your systems. All of those basic blocking and tackling things from a cybersecurity perspective, we always should have been doing, they'll still apply in an interoperability environment. So With that out of the way, let's take a quick moment to review what we've covered today. Today, we define interoperability. We took a look at the definition, different solutions, terms, and define those, as well as the history of interoperability. We took a look at what interoperability means to you from both individual and provider perspective. We discussed interoperability for HCBS and LTSS environments and gave an example for MediSked, as well as some additional use cases. Then we moved on to taking a look at the history of federal policies and security considerations. We looked at that timeline, which includes some major regulation around this, including HIPAA, NIST, HITECH, the 21st Century Cures Act, TF Draft 2, and ONC and CMS final rules, as well as the CIA triad and general security practices for interoperability. And then we talked about what you should be doing about interoperability. We talked about what you should be looking for. We talked about the checklists that CMS provides for you, as well as general security considerations. With that being said, we're very close on time. And this is really a lot of information that we're covering. So we've provided references for you for all of the major references throughout the document on these two slides, which the slide will be available for you as well. And we've bolded a few of them that give you some specific things like the Beyond Corp or the CMS checklist that may be helpful to you in the future. And if you haven't already entered your question in the chat, feel free to email either Heather or myself. Here are our email addresses. And what we'll do is we'll try to answer all those questions as quickly as possible, hopefully within the next 24 hours, and get the responses back, as well as some of those attachments out to all individuals who participated in today's webinar. With that being said, we really appreciate your time. We hope this has been instructive for you as it's been for us, and we look forward to working with you in your journey for interoperability.
Thank you, everyone.